And the Nebido form, the 3-month injectable form, is, I think, the best form of best preparation in this regard, because you know that it's been given, because it's given by a healthcare professional, and it lasts for quite a long time, up to 3 months. So in clinical trial work, we don't have a problem with compliance. This paper was published this year, and it's thrown an increased controversy into the area of testosterone replacement therapy in men, because it suggested, the study was stopped earlier because of an increased cardiovascular risk associated with replacement therapy. And it was a study looking at frail elderly men to see if testosterone replacement therapy would improve their exercise capacity, muscle strength, and so on, and it did. So it's a positive trial, even though it was stopped early. But it was stopped because of these adverse events. Only one event on placebo and a significant number of events on testosterone. This is an outlier. As I said, we've been actually not looking at frail elderly men. We've been looking at men with documented heart disease over 15 to 20 years, and we haven't seen this phenomenon, certainly not within a 3 to 6 month period that these authors have demonstrated. So I'm not sure how to explain this. All I can say is that that's not been our experience. So, in summary, testosterone deficiency is associated with a pro-atherosclerotic risk profile. In animal models, it's certainly associated with increased atherosclerosis. In man, there's evidence of increased non-invasive markers for atherosclerosis. There's unequivocal evidence now with at least 4, and I've refereed other papers, there are more papers coming out showing that low testosterone increases cardiovascular and total mortality. Testosterone replacement therapy improves exercise capacity in men with angina. Several studies showing this, and it improves exercise capacity and quality of life in men with heart failure, and possibly women. There's only been one study of low-dose testosterone in women. So what about the future? Should we be using male hormone replacement therapy more regularly? Should it become part of our armamentarium of modifying cardiovascular risk in our elderly males? Certainly, I feel that men with metabolic syndrome should be screened for hypogonadism. You can spot them when you come into the clinic. Type 2 diabetes, commonly associated with abdominal obesity in man. But in those men with abdominal obesity, type 2 diabetes who are hypertensive, at least 50% of them will have a significantly low level of testosterone. And I'm not just talking about the borderline area, I'm talking about frank hypogonadism, less than 8.7 nanomoles per litre. Should testosterone replacement therapy be given to men with low levels? Well, you replace thyroid hormone to men with low thyroid hormone, so I don't see why you shouldn't think about replacing testosterone. And in the studies that have done that, there are very positive benefits. We don't know about the long-term safety, and we don't know the effect of prostate cancer, except there's a large body of evidence to suggest that replacing testosterone to physiological levels doesn't in fact increase the risk of prostate cancer. What about can we convert those Kaplan-Meier curves showing increased mortality in a low testosterone population back to normal by testosterone replacement therapy? That's the key. That's the unanswered question. We need a large epidemiological study, a large treatment study over 5 years, placebo-controlled, to prove that. And we don't know. So I recommend that you seriously think about testosterone replacement therapy in your men, but please don't give too much. Thank you very much.
Thank you very much, Professor, for the excellent and very informative presentation. We have several minutes for questions and comments. Please. I wonder whether, Professor, yourself use...
Hello, my name is Dr. Razak from Pakistan. In case of the testosterone deficiency, is it mandatory to do PSA before starting therapy?
Yes. Yes, I'm a cardiologist and I don't treat people with testosterone. I send them to my endocrinological colleagues who properly work them up and measure FSH and LH and work out why their testosterone level is low. Sometimes it is related simply to the older age effect, but sometimes it is related to pituitary disease. So they're properly worked up, and you need to do digital rectal examinations to make sure there isn't any prostate abnormality, and PSA, yes.
Thank you.
Any further question? I just wonder that now not yet for the recommendation to use testosterone in the elderly.
To use it in the elderly?
Yeah.
Well, I mean, I think that this paper from the New England Journal has obviously upset the apple cart a bit. I think that I'm much more comfortable using testosterone in men with overt heart disease, because I know that heart failure is associated with a 50% mortality within 5 years and is a very morbid condition. And if I can give anything which helps with symptoms, never mind helps with survival, then that's a good thing for my patients. They're going to die anyway from heart failure. If I can improve their quality of life, that's a good thing. So I actively screen my patients, with my male patients with heart failure, to look if we can give additional therapy with testosterone because of the proven benefits, with all the, the riders about checking their prostate and so on. In terms of angina, nowadays we have such effective treatments for angina by intervention, coronary artery bypass surgery. We have few men who have resistant angina. So it's less of an issue. There are cohorts of men who are resistant, who have a recurrent angina following coronary artery bypass surgery and angioplasty, and that population, certainly we would look at other ways of helping them. But the main clinical area that I use it in is heart failure. Now, these patients are often frail and elderly, but I don't recommend testosterone replacement therapy for simply an old, frail man, because I don't see them. I see them when they have heart disease. Okay.
If there's no further question, please join me. Thank you, all of the speakers. Thank you, Professor. I declare the section closed.